Hi, everyone. My name is Phil Gehrman. I am the current president of the Sleep Research Society Foundation, and it's my pleasure to welcome you to today's webinar focusing on the results of a Focused Research Award sponsored by the foundation. Today, we're going to hear a report of the results from Drs. Kaufmann, Bhattacharjee, and Park, and they're going to be talking about their research narcolepsy and cardiovascular disease, insights from pharmacoepidemiologic research. And so it's my pleasure to turn it off to Dr. Kaufman, who's going to get us started.
Thank you so much. It's so wonderful to be here. We're very much excited to present our findings for you today to the sleep research community. And before we begin, I thought we would discuss what the SRSF Focused Research Award mechanism is. This was a national call for research proposals where applications were peer-reviewed by the SRS Scientific Review Committee, utilizing the NIH standards. And our team was fortunate to be awarded to use real-world data to investigate links between narcolepsy and cardiovascular disease. And today you will hear from three people, myself, Jesus Park, and Rakesh Bhattacharjee. My name is Chris. I'm an assistant professor in the Department of Health Outcomes and Biomedical Informatics at the University of Florida College of Medicine. And I'm primarily an epidemiologist who studies sleep and aging and the impact that sleep treatments might have on aging outcomes in later life. Jesus Park is an associate professor in the Department of Pharmaceutical Outcomes and Policy at the University of Florida College of Medicine. She is a pharmacoepidemiologist and pharmacist whose research focuses on health and economic outcomes of medications. And finally, Dr. Rakesh Bhattacharjee is the section chief of pediatric sleep medicine at Rady Children's Hospital in San Diego. And he's a professor at UC San Diego in their Department of Pediatrics. His research interest focuses on pediatric sleep medicine and its cardiovascular consequences. And this work is not just us three, it's part of a broader team from four institutions, including the University of Florida, University of Pittsburgh, UCSD, and University of Maryland, Baltimore. At UF, it includes myself and Jesus, as well as Munaza Riaz and Debbie Wilson. At the University of Pittsburgh, we included Jenny Losinik. And at UCSD, both Rakesh and Atul Malhotra. And finally, at UMB, Emerson Wickwire. And we're excited to present our results to you today. So today, this is an overview of what we're planning to discuss. I will first describe narcolepsy and cardiovascular disease, providing a background for our project aims and scientific rationale. I will then hand it off to Jesus, who will discuss the methods and results for AIM 1. And finally, Rakesh will take the reins and discuss AIM 2, as well as the clinical implications for this work. So before we begin, we thought that it would be good to provide a groundwork for what our project was about. And let's first talk about what is narcolepsy. So narcolepsy is a rare, lifelong, and debilitating neurological disorder that causes excessive daytime sleepiness and sudden sleep attacks. It leads to disrupted nighttime sleep and can include cataplexy, which is a loss of muscle tone due to heightened arousal, as well as hallucinations and sleep paralysis. The International Classification of Sleep Disorders, third edition, categorizes it into two forms, type 1 and type 2. Type 1 corresponds to excessive daytime sleepiness with cataplexy. And this is associated with low CSF hypocretin levels. And type 2 is excessive daytime sleepiness without cataplexy. And this is generally associated with normal hypocretin levels as well. A number of studies have investigated the role of narcolepsy in cardiovascular disease. And there are a number of potential mechanisms, but in this presentation, we want to highlight three. And that is inflammatory pathways, lifestyle and metabolic factors, as well as autonomic dysfunction. So in terms of inflammatory pathways, hypersomnolence is central to both types of narcolepsy, type 1 and type 2. And excessive daytime sleepiness is associated with elevated levels of inflammatory cytokines such as IL-6 and TNF alpha. These play roles in promoting C-reactive protein synthesis, which is a key cardiometabolic risk factor. In addition to inflammatory pathways, there are also lifestyle and metabolic factors at play as well. So disturbed sleep in general may lead to weight gain due to increase in intake of high-calorie fatty foods, as well as sedentary behavior. In addition, many of the comorbidities that often co-occur with narcolepsy are often linked to CVD as well. And finally, autonomic dysfunction. So people with narcolepsy often experience what's called non-dipping blood pressure pattern at night. And this is when the blood pressure doesn't drop the way it should at night. One of the key reasons for this is sleep fragmentation, which ramps up sympathetic nervous system activity into a stress mode, which over time may lead to autonomic dysfunction and contribute to high blood pressure. And what's more, this cascade creates pro-atherogenic environment, promoting conditions that damage the lining of blood vessels and drive systemic inflammation. And together, these pathways lay the groundwork for atherosclerosis and ultimately increase a person's long-term risk for cardiovascular disease. So we've talked about three potential mechanisms, and it follows that maybe these narcolepsy results in various clinical outcomes, cardiovascular clinical outcomes as well. And that was recently studied in a very large retrospective cohort study called the CV-BOND study. This study used data from IBM MarketScan Administrative Claims Database from 2014 to 2019 and included just under 13,000 adults with narcolepsy and 38,000 matched controls. Ultimately, what they found is that narcolepsy is associated with a 47% increased risk for MACE, major adverse cardiovascular events, and a 32% increased risk for CVD. So in the work that we've presented thus far, there does appear to be evidence to suggest that narcolepsy is associated with increased risk for cardiovascular disease. However, 4 questions remain. The first, what about comorbidities? So patients with narcolepsy have higher rates of comorbidity. This might include depression, anxiety, diabetes, and other sleep disorders. And in fact, up to 50% of narcolepsy patients have comorbid OSA, which we all know is known to increase cardiometabolic risk factor. And so one of the questions is it the narcolepsy that's leading to cardiovascular disease, or is it these comorbid conditions that are driving that association? Another question is, what about medications used to treat narcolepsy? So stimulants are often used to treat the hypersomnolence and other narcoleptic symptoms. And they're also often result in elevated heart rate and high blood pressure. And over time, these cumulative effects might increase risk for CVD. Third, what about subclinical cardiovascular disease? And when we talk about subclinical cardiovascular disease, we're talking about those early asymptomatic changes in the cardiovascular system that occur prior to clinical events, such as stroke and heart attack. And patients with narcolepsy may show early vascular changes, potentially driving the mechanisms previously discussed. And therefore, it's important to study subclinical CVD outcomes because they might help reveal insights into mechanisms linking narcolepsy to long-term cardiovascular risk. And the final question is, what about childhood? Narcolepsy is not just a condition in adulthood. It actually has much earlier manifestations. This is data showing the age of onset of narcolepsy symptoms. And as you can see, across the entire life course, they do show onset of symptoms, but there is something interesting. This shows a bimodal distribution such that most patients' symptoms start before the age of 25. And in fact, there's often a 10-year delay before clinical diagnosis. So, given that CVD is a condition later in life, and narcolepsy is a condition earlier in life, it's possible that narcolepsy could be a risk factor, if not modifiable disease risk factor, for subsequent development of CVD. And with all that in mind, our project sought to determine the association between narcolepsy and subsequent risks for two things. In AIM-1, we looked at major adverse cardiovascular events as well as CVD. And in AIM-2, we looked at the subclinical CVD outcomes. And these included hypertension, hyperlipidemia, and diabetes, and MAFLD NASH. And what we aim to do in these analyses is to carefully account for confounding comorbid conditions like OSA, as well as stimulant use, and also to evaluate differences in associations across the entire life course, including children. And with that, I would like to pass this off to my colleague, Heisuk, who will be discussing the methods in AIM-1.
Thank you so much, Chris. My name is Heisuk. I'm very excited to share the method of our study, including AIM-1 and 2, and findings from AIM-1 of the study. Next. This slide summarizes overview of our method. First, we used the market scan database covering the years 2005 through 2021, which includes 17 years of commercial insurance claims data. And we established two cohorts. One individual with the diagnosis of the narcolepsy and a control group without narcolepsy. And we had two different aims. The first aim, as Chris explained before, we mainly focus on CVD and MACE outcome. And for aim 2, we dive into subclinical cardiovascular disease outcome, including hypertension, hyperlipidemia, diabetes, and MAFLD and NASH. And we utilize 1, 2, 3 propensity score matching. We matched each patients with narcolepsy to up to 3 control patients with similar characteristics based on their propensity score, ensure the comparability between these two groups. And we also employed time-dependent Cox proportion hazard model. I'll explain more about the statistic method in next couple of slides. Next. Study population, we first included patients in the narcolepsy group if they had at least 2 outpatient claims with a diagnosis of narcolepsy, identified using ICD-9 or ICD-10 codes for type 1 and type 2 narcolepsy. To avoid some cases when narcolepsy was documented solely for purpose of diagnosis testing before results were available, we require that at least one claim should include a narcolepsy diagnosis without any associated diagnosis procedure that we listed here, including multiple sleep latency test and home sleep apnea test, etc. And then so that's how we established narcolepsy group. And then for control group, we first performed 1 to 300 matching based on age, sex, diagnosis date, narcolepsy diagnosis date to narrow the pool of potential controls. Then we apply PS matching using baseline covariates to balance the comparison groups. These baseline covariates included demographics, comorbidities known to be associated with increased risk of cardiovascular disease, as well as medication use. Next. We further excluded patients with any prior diagnosis or procedure for CVD or MACE for AIM-1 to ensure the incident cases of CVD or MACEs. For AIM-2, we further excluded patients had any diagnosis for hypertension, hyperlipidemia, diabetes, or MAFLD NASH, in addition to CVD or MACE. So both aims, we completely excluded anyone who had outcome of interest. Next. So the primary outcome of interest for aim 1 was instance cardiovascular disease, including stroke, AFib, heart failure, MI, or acute coronary syndrome. And for instance MACE, we included ischemic stroke, heart failure, MI, acute coronary syndrome, and CABG or PCI procedures. For aim 2, for the subclinical cardiovascular disease outcome, we included instance hypertension, hyperlipidemia, diabetes, and MAFLD and NASH. Next slide. So this graph shows the brief summary of our study design. For narcolepsy group, we defined the date of first narcolepsy diagnosis as the index date. For the control group, the index was the date of matched medical encounters that we identified. And we follow patients from the index date to the first occurrence of any clinical outcomes and end of continuous enrollment or end of study period, which was December 31st, 2021. Next, after employing PS matching, we assess the difference in baseline characteristics using absolute standardized mean differences with a value less than 0.1, indicating good balance between two groups. So we conducted this testing before and after PS matching. And then we utilized time-dependent Cox proportion hazard regression model adjusted for both time-fixed medication use during the baseline, including stimulant, wake-promoting agent, and also time-varying stimulant use, which means those patients who utilize stimulant after their diagnosis of narcolepsy, we actually control for those medication use. And we conducted a subgroup analysis by age group, sex, type of the narcolepsy, type 1, type 2, and presence of comorbidities. Next slide. So here is our findings. I'm very excited about our findings for aim 1. Our findings are currently under revision at Sleep Journal. Next. We initially identified 90,684 patients with narcolepsy. After applying inclusion and exclusion criteria, performing propensity score matching, our final analysis included 34,562 patients with narcolepsy and about 100,000 patients matched control without narcolepsy. Next. This graph shows the overall distribution of a propensity score before and after PS matching. And as shown on the right-hand side, our propensity score, overall propensity score match were well distributed, and we achieved good balanced groups. And we look into each individual covariates, how they were well balanced after PS matching. So next slide, please. So this graph here shows individual covariates we included in PS matching. Following PS matching, all covariates included in the model were well balanced between two groups based on absolute standardized mean difference less than 0.1. And for example, if we look at sleep apnea here, let me use the sleep apnea here. Before PS matching, absolute standardized mean difference between two groups was 0.9, which means there was statistically significant difference between two groups, which was, we used the orange dot before PS matching. After PS matching, as you can see here, blue triangle indicates there is no statistically significant difference between these two groups, and the mean standardized difference is well below 0.1. So we actually achieved very successful matching, which minimized some of confounding issues between two groups. Next. So for AIM-1, here is our baseline characteristics. So after matching, if we look at narcolepsy cohort, the overall mean age of the narcolepsy cohort was 39 years old, and 26% were younger than 25 years old. About 62% were female. Regarding some of the comorbidities, 38% of patients had sleep apnea, 20% had hypertension, another 20% were prescribed with selective serotonin reuptake inhibitor, SSRI, during the baseline period. And as I mentioned before, all this standardized mean difference was less than 0.1, indicating very well-balanced cohort for our analysis. Next. So this is our main findings: risk of cardiovascular disease in MACE with or without narcolepsy. And following PS matching, the time-dependent Cox regression model adjust for stimulant use during that time period, during the follow-up time, suggests that narcolepsy was associated with an 89% increased risk of CVD and 95%. So 89% for CVD, 95% increased risk of MACE, respectively. And we also look into, next, thank you. We also look into individual cardiovascular event. We also observed increased risk of individual cardiovascular outcomes, including stroke, heart failure, MI, and AFib among patients with narcolepsy compared to control group. So all these point estimate adjusted hazard ratio was above 1, and some of them actually was close to twofold. And subgroup analysis. And in subgroup analysis for CVD risk by different age group and different sex and different comorbid conditions, including sleep apnea, hyperlipidemia, diabetes, hypertension, and even different narcolepsy group, the increased risk of cardiovascular disease, patients with narcolepsy compared to control remain consistent. Next, this graph shows subgroup analysis for MACE outcome. Similarly, in subgroup analysis by age group, sex, comorbidity, the increased risk of MACE in patients with narcolepsy compared with the control remain consistent with the main analysis. So with this, I'll let Rakesh take over and then share some of our findings for AIM-2 and discussion.
Hi, good morning, and to those east of me, good afternoon. I'm very excited to present our findings from AIM-2, which has been recently published in the Journal of American Heart Association. Chris, if you don't mind, send the next slide. So as Haisuk mentioned, we used a very robust methodology for AIM-1 that we mimicked in AIM-2. Namely, we utilized a large cohort of patients of narcolepsy. And after AIM-1, there are 34,562 patients. But in AIM-2, our primary focus was to look at the incidence of subclinical cardiovascular outcomes. Therefore, it was prudent that we had to exclude these conditions at baseline. So taking that 34,562 patients, if we excluded patients with diabetes, hypertension, hyperlipidemia, and MAFLD and NASH, our numbers, the cohort did reduce in size to about 22,305. Nonetheless, we still feel this is a very large cohort of patients of narcolepsy, considering this is a rare disease. Again, we utilized propensity score matching, and we were able to sample from a very, very large population of control patients of over 3 million. And again, with that control population, we had to exclude the patients that had subclinical cardiovascular disease, rendering a sample size of about 2.5 million. Now, as we have mentioned before, what is critical in our methodology is propensity score matching, because we firmly believe that we need to account for demographic factors, potential confounding variables, as well as medication use. And so following propensity score matching, our control population went down to about 63,000 at about a ratio of 1 to 3. Next slide. So this is very similar to a format of table as to the table that Heisuk presented, where we looked at our population both before and after propensity score matching. And again, just to emphasize, this is a smaller cohort, but it's still well over 20,000 patients. And one thing I want to highlight here, when you exclude patients with subclinical cardiovascular disease, as we expected, the cohort would become younger. So before propensity score matching, our age of patients for narcolepsy was about 33 years of age. And then following propensity score matching, that remained, and our control population was also younger in the age of 33%. We also saw an uptick in the number of patients that were under 25 that we identified as the pediatric cohort. So we saw that about almost 40% of patients were under the age of 45, and only about 1.6% were over the age of 65, suggesting that the smallest cohort was the elderly cohort. We had at about 65% of the cohort were female. And again, following propensity score matching, as you can see, looking at the absolute standardized mean difference of less than 1, both the narcolepsy group as well as the patients without narcolepsy were well balanced for very important confounding factors such as sleep apnea, obesity, mental health disorders, as well as baseline medication use, including looking at cardiovascular disease medications and mental health medications such as SSRIs, SNRIs, and sleep medications such as benzodiazepines and Z drugs. Next slide. So looking at the two groups, this is the summary of the entire cohort of 22,000 patients with narcolepsy versus 63,000 patients without narcolepsy. And what you can see, like if you look at the odds of developing hypertension, hyperlipidemia, diabetes, and MAFLD, you can see that clearly the first three are much more common than MAFLD. MAFLD, the incidence was low for both groups. And that's not to our surprise. This is a relatively newcomer. We are now starting to see an increase in screening for liver disease related to fatty liver. But comparing it to conditions like hypertension, hyperlipidemia, and diabetes, clearly those three had a much higher incidence in both patients with narcolepsy versus patients without narcolepsy. Now, if you compare patients with narcolepsy versus without narcolepsy, as you can see in the adjusted hazards ratio, there is a significant increase in all of these outcomes, including MAFLD, where we're seeing an increase of about 1.5 times in the incidence of hypertension, hyperlipidemia, diabetes, as well as MAFLD. So clearly there seems to be a link between the onset of subclinical cardiovascular disease, even following using our methodology of propensity score matching. Next slide. Now, what was critical for AIM-2 is our subgroup analysis or stratified analysis. So we looked at each subclinical cardiovascular outcome and wanted to look at how this performed with different age groups, different sex, whether patients had or did not have sleep apnea, and at the very bottom, comparing patients type 1 versus type 2 narcolepsy. And so if we look at hypertension in this slide, if you look at the age group, you can see at least for the first three groups, there was a significant increase in the risk of hypertension, including patients under 25, where we don't typically expect patients to deal with hypertension, but our findings do show that, compared to patients without narcolepsy, there is a significant increase in the risk of hypertension. Now, patients over 65, again, I mentioned that this was not a very large cohort, and we did not see a significant increase, but more a trend towards increase in the risk of hypertension. In both males and females, we saw that the risk of hypertension increased. And then in patients with and without sleep apnea, we also saw an increase in the risk of hypertension in patients with narcolepsy compared to patients without narcolepsy. And then following, if we looked at patients with type 1 and type 2 narcolepsy, we saw that both groups had a significant increase in the risk of hypertension. Next slide. Now, if we look at hyperlipidemia, our other subclinical cardiovascular outcome, again, if we look at age, we see that at least for the first three subcohorts, there is a significant increase in the risk of hyperlipidemia. Perhaps we did not see this increase in the age over 65. Again, this may be related to a smaller sample. But again, emphasizing that patients young, under the age of 25, had a significant increase in hyperlipidemia if they had narcolepsy compared to patients that did not have narcolepsy. Looking at sex, we found that this association was observed in both males and females. We also observed this association to be present in both patients with sleep apnea and without sleep apnea. And finally, when we looked at patients with type 1 and type 2 narcolepsy, we saw that in both cohorts, in both groups, there was a significant increase in the risk of hyperlipidemia. Next slide. Now, looking at diabetes, again, I might sound like a broken record, but we're really seeing very similar observations across all these incident subclinical cardiovascular outcomes. So we know that diabetes, there was a significant increase in the risk for patients with narcolepsy. And if you looked at the age groups subgroup analysis, you see that observation was definitely present in at least the first three age cohorts, under 25, 26 to 44, 45 to 65, and perhaps a trend, but a non-significant increase in those patients over 65. Looking at sex, we saw that both males and females, there's a significant increased risk of diabetes in patients with narcolepsy compared to patients without narcolepsy. In both groups of sleep apnea and patients without sleep apnea, we saw an increased risk of diabetes. And in both narcolepsy types, type 1 and type 2, we saw that the risk of diabetes was increased. Next slide. Now, finally, looking at MAFLD, and again, highlighting that while there was a significant increase in the risk of MAFLD in patients with narcolepsy versus patients without narcolepsy, this was a relatively low incidence rate of 0.42 compared to 0.28. Nonetheless, the expectation is that perhaps with the low sample size, we may not see such an increase in the subgroup analysis. We did see some trends where perhaps there was an increase in patients under 25. There was a statistical significant increase in patients 26 to 44, and we did not observe an increase, but trend increase in patients 45 to 65. And in patients over 65, there really didn't seem to be that association. In terms of comparing males and females, while we didn't see a statistically significant increase in males, we did see this in females. For both patients with and without sleep apnea, we did see a statistically significant increase in the risk of MAFLD and NASH. And in terms of looking at type 1 and type 2 narcolepsy, we observed an increased risk in type 2 narcolepsy and a trend increase in patients with type 1 narcolepsy. So again, this is a little bit marred by the fact that the incidence of MAFLD and NASH is a lot smaller compared to the three aforementioned subclinical cardiovascular outcomes, but we do observe that there is this trend, at least in some of these subgroups. The next slide. So to summarize our findings and what this means in the clinical arena, I'd like to kind of go over just some of the important considerations that we had as a group when we designed the study. Next slide. So, one of the things that was quite wonderful about our group is that we had experts in spanning the age range. So I as a pediatrician was quite intrigued by patients who were younger. Chris and his expertise in gerontology is quite familiar with issues related to patients who are elderly. So we really wanted to capture cardiovascular disease outcomes in the entire age spectrum. And so we did not exclude any patients. We looked at younger patients, we looked at older patients, and we wanted to really see the evolution of this risk of cardiovascular disease in patients with narcolepsy. And while we had that sort of as the backbone of our study design, what was important was keeping in mind, what Chris kind of alluded to in the four questions, is we wanted to keep in mind the importance of confounding conditions, including sleep conditions like sleep apnea, restless leg syndrome. We wanted to, recognize that patients with narcolepsy have higher rates of mental health disorders, including depression and anxiety. And so we wanted to make sure that that was something that was adjusted. Patients with narcolepsy use medications including stimulants and other types of narcolepsy medications, which can have an influence on cardiovascular disease. And of course, as we all know, when we think about cardiovascular disease, it's critical to look at the impact of age and sex. And so these were sort of, we looked at designing our study, but really making sure that we are keeping our mind very open to all the possible confounding influences of different factors. Next slide. So, taken together, I think I believe that our study has numerous strengths. And so first, it is a large database. This is, to our knowledge, the largest cohort of patients with narcolepsy. And considering this is a rare disease, using insurance claims, it affords us the opportunity to really have cohort sizes of narcolepsy over 20 and up to 30,000 patients. And since we had data going back to 2005, we really had a long study period to capture a lot of these outcomes to really give us a sense of the natural history of cardiovascular disease in patients with narcolepsy. We included children, so we included patients under 25. That really helps in terms of broadening the findings to include a cohort that is already understudied. And so now we believe that the findings from both studies will help those pediatric specialists that treat children with narcolepsy. And then mostly, like if we looked at our study methodology, again, as I mentioned, the importance of propensity score matching, all of the hazards ratios that we've reported took into account baseline medication use, including stimulants, as well as time-varying use of stimulants, which we all know that these medications themselves cause cardiovascular disease. So what we are reporting for the first time is an association of narcolepsy and cardiovascular disease independent of these medications. Next slide. Notwithstanding, we can't boast about our study being the perfect study. We recognize that there are limitations to our study. First, we relied only on diagnostic codes. We don't, using a claims database like MarketScan, we don't have granular data that we can actually verify these diagnostic codes. For example, we don't know what the mean sleep latency of these patients were when they had a multiple sleep latency test. If they had a lumbar puncture for CSF hypocretin levels, we would not know what those values are. We just know what the diagnosis was. There is the chance that there could be an element of detection bias, that those treating patients with narcolepsy may be more cognizant of the potential for cardiovascular risk, particularly if they're on medications. And so therefore, they may actually undergo more screening for earlier detection of cardiovascular disease. And we recognize that one of the limitations of our study could be related to detection bias. Generalizability, one of the limitations of MarketScan broadly is it does not contain information about race and ethnicity. It does not include patients who are publicly insured. This only includes commercially insured patients. And so looking at whether this applies to the entire population of the United States, I don't think we can really safely say that. Certainly there are the influences of socially determinants of health may factor in, particularly under the realm of cardiovascular disease, and this is likely underreported in this database. Nonetheless, all of these factors probably affect both the control as well as the narcolepsy group. But again, we have to be mindful that there's limited generalizability just related to the inherent nature of MarketScan. And finally, there's the good chance that obesity was underreported. Obesity, as we all know, is a critical risk factor for cardiovascular disease. And this is related to the lack of BMI data that's reported in MarketScan. Now, we did rely on obesity diagnosis. We also relied on surrogate diagnoses such as hyperlipidemia and MAFLD, so we could control for these. But if we have a patient that has an extremely elevated BMI versus one patient that does not have extremely BMI, it would be treated equally. And so this may have had an influence on our study findings. Next slide. So this is really the summary of cardiovascular disease risk in patients with narcolepsy, looking at the entire cohort. You can see that for subclinical cardiovascular disease outcomes, there's nearly a 1.5-fold increase in these incident outcomes. And then if we look at advanced outcomes such as cardiovascular disease or MACE, we see a near doubling of the risk. And these observations were following propensity score matching as well as following adjustment for baseline narcolepsy medication, as well as time-varying stimulant use. Next slide. Now, it would be, I want to take this chance to really sort of plug the importance of our study with regards to being really the first study to capture the essence of why we need to consider pediatric narcolepsy. As Chris mentioned to you, that really narcolepsy starts early in life, often can be considered a pediatric disease since the majority of patients start during childhood. It was sort of prudent for me to make sure that we included this group. If we think about cardiovascular disease or acquired cardiovascular disease, we don't often think of this as a real entity in pediatrics. But what we observed is a near doubling of the risk of incident subclinical cardiovascular outcomes of hypertension, hyperlipidemia, and diabetes, and an increase, although not statistically significant, MAFLD. But I think, if we want to really advocate for trying to alert clinicians about why cardiovascular disease is important in narcolepsy, I think our study really establishes the fact that we need to think about this very early in the life course of narcolepsy. Next slide. Now, we also looked at characterizing narcolepsy type 1 and type 2. While our study was not designed to compare narcolepsy type 1 and type 2, we looked at both groups independently, and we found that in both groups there was an elevated risk of cardiovascular disease. Now, we know phenotypically type 1 and type 2 behave differently, mainly related to the onset of cataplexy, but also pathophysiologically in terms of the amount of orexin or hypocretin in the cerebrospinal fluid. Nonetheless, there is common features for both conditions. Namely, both groups have excessive daytime sleepiness and both have significant sleep fragmentation. And as Chris mentioned, like sleep fragmentation will disrupt sleep quality, activate sympathetic nervous system activity, may reduce nocturnal blood pressure dipping, and perhaps this is the unifying component of narcolepsy that links narcolepsy with cardiovascular disease. And again, this remains to be, this is a question that we want to ask in further studies. But I think, looking at our findings, we can at least say that it didn't matter if you're type 1 or type 2, both groups had an elevated risk of cardiovascular disease. And one thing I think is quite interesting and again remains to be studied, but certainly something that we should think about in future study designs is this idea of excessive daytime sleepiness. So, there are studies in sleep apnea linking cardiovascular disease with sleep apnea, and perhaps the risk seems to be greatest in those patients who have a sleepy phenotype of sleep apnea rather than a non-sleepy phenotype of sleep apnea. And so this may be why patients with narcolepsy have such a high level of cardiovascular diseases, because 100% of these patients have excessive daytime sleepiness. And so we believe this is really the key driver of cardiovascular disease in sleep disorders. And I think the perfect example would be studying patients with narcolepsy. Next slide. So in summary, we think that looking at both type 1 and type 2 narcolepsy, there is an increased risk of cardiovascular disease, both advanced cardiovascular outcomes like CVD outcomes in MACE, as well as subclinical cardiovascular disease. This is the first study to really provide compelling data to link MAFLD or NASH with narcolepsy. This is also the first study to really show a compelling risk of cardiovascular disease risk in patients under 25. Using propensity score matching, we believe that this association of narcolepsy and cardiovascular disease is quite strong because we controlled for very, very relevant confounding comorbidities such as sleep apnea, mental health disease. We also adjusted for medications, and we looked at age and sex groups and really provided a compelling story looking at the onset of cardiovascular disease in patients with narcolepsy. And again, while this is something that remains to be studied, but we believe that the mechanism that may be explaining these associations is daytime sleepiness and sleep fragmentation, which may be why we're seeing such a profound increase in patients with narcolepsy. Next slide. So we wanted to take this opportunity just to say how gracious we are to the Sleep Research Society Foundation for not only presenting our findings today, but just the opportunity for all of us all of these investigators, very diverse backgrounds from, as Chris showed in one of our slides, very diverse geographical backgrounds where we could really come together, work harmoniously, and really characterize narcolepsy and cardiovascular disease. We really are appreciative of you attending our seminar today, and the official recording of this webinar will be provided to all attendees on the SRS Foundation website when available. We thank you very much.
Great. And so we do have some questions on the Q&A, and we're happy to take any more questions that you have. Ideally, it would be within the Q&A feature in your Zoom screen. But do you guys, Rakesh and Jesus, do you guys see the Q&A as well?
Yeah. All right. So the first question is, thank you for the clear, informative data presentation. Thank you very much. Why do you value secondary data analyses from claims database to address these clinical questions? So I'll take the first stab at this. With regards to a rare disease such as narcolepsy, it can become challenging, unless you have robust multi-center approaches, which can be costly, where we can really collate all these patients with narcolepsy together, but still get a relatively small sample size. I think the aspect of using a database like this really gives us an opportunity to use big data to address the questions that we had. Jesus and Chris, did you want to add to that?
Go ahead, Jesus.
Yeah, sure. I echo what Rakesh said. Secondary claims database has some limitations. However, this allows us to do longitudinal follow for large cohort patients with rare disease conditions such as narcolepsy. So can answer some of the questions. It's hard to be answered for the clinical trials.
And I echo everyone else. So the next question is, and maybe this is something, Rakesh, you can take on, but
Yeah,
how
sure.
do you expect these results to impact clinical care and treatment decision-making?
So this is a great question. I mean, at the end of the day, looking at this data and how we apply it is really the critical question. And I think we present a very compelling case, really strengthening the association of cardiovascular disease and narcolepsy. And so I think when patients are being seen for narcolepsy, this is something that needs to be detected, needs to be an element of focus in terms of how you treat these patients. But given that cardiovascular disease remains one of the top reasons for mortality in the United States, if you have patients with sleep disorders like sleep apnea, but now narcolepsy, we think that it is very important that the cardiovascular disease gets detected and treated early, including whether this is pharmacological or non-pharmacological interventions. Because at the end of the day, while we're trying to improve the lives of our patients with narcolepsy, we're also trying to, in terms of their sleepiness, we're also trying to improve their lives in terms of preventing morbidity.
Great. The next question, I can take this on. Do these results support narcolepsy as an independent risk factor for CVD? Is in all observational studies, there are always limitations. But I think one of the strengths of this study is the pharmacoepidemiology expertise we had on it, that we were able to really account for some of those confounding factors like sleep apnea. And so while this doesn't, you can't say for definitively whether it's an independent risk factor for CVD, we can at least say that it's independent of the factors that we accounted for in our propensity score models. So there's one more here. Given the efficacy of sodium oxybate for NT1 coupled with your data showing increased CV risk in the pediatric population, what are your concerns about years of the associated sodium intake with oxybate potentially exacerbating CV risk?
Yeah, I'll take an answer to this question first. So this is a very interesting question. Again, we saw really, like in both narcolepsy type 1 and narcolepsy type 2, an increased risk of cardiovascular disease. Generally, oxybate therapy is targeting narcolepsy type 1 patients. And we saw that that again, there was an increase in cardiovascular disease risk. Our study design was not able to really address this question per se in terms of looking at the impact of oxybate. But we do recognize that if patients have cardiovascular disease risk or have cardiovascular disease, there needs to be steps taken to minimize or reduce cardiovascular disease later in life, including being mindful of sodium intake, being mindful of exercise, being mindful of blood pressure monitoring or blood sugar monitoring. So I think this is sort of a future direction for our group, looking at how we can see what is effective in actually reducing cardiovascular disease risk in patients with narcolepsy. But I think our study really sets the foundation that these questions need to be addressed.
Great. Are you able to see the questions as well?
Oh, yeah. I'll
out?
read the next one. So thank you for presenting my question. Since the youngest age cohort is under 25, including children, what do we call this cohort? It is not just children, maybe children and young adults less than 25. Yeah, this is a good question. We kind of identified the pediatric cohort under the age of 25. Now, I know in the pediatric world, some people would hate me for saying that. It's really under 18. I will say that there are certain social issues that have factored in for patients 18 to 25. And I think the biggest social issue is the actual Affordable Care Act, which has identified people under the age of 25 sort of remaining on their parents' insurance plan. And when they are in college, they are also, I have found in my clinic that a lot of the patients who are off to college want to still be followed by their pediatrician. They've got too much on their plate dealing with college, and so it's not unlikely that some patients will be asked that they will be followed by their pediatrician to treat their narcolepsy. So given sort of the ACA and given sort of our observation clinically, we kind of lump these two together. Now, keeping in mind, if we think about pediatrics being a time of growth, it's really, at the end of puberty where growth is sort of stopped, and that tends to be around 16 to 17 years of age. But if you include 18 as an age for pediatrics, I don't know really the difference of an 18-year-old versus a 21-year-old. So I think it's sort of becoming a little bit of a redefinition of pediatrics, given what the Affordable Care Act has done. All right, next question. What are your thoughts on eventual approval of orexin agonists and an impact on these diseases, especially cardiovascular disease? Yeah, I'll take this one as a clinician. This is a really, I think, very intriguing question, just given the latest with regards to orexin agonists to treat narcolepsy and potentially reversing sleep fragmentation in patients with narcolepsy. I think it will be interesting to see, as medications as we gain greater efficacy to treat narcolepsy with more novel agents. Could this arrest not only the onset of, or at least improve the excessive daytime sleepiness in this group? Could this actually arrest some of the comorbidities related to narcolepsy, including cardiovascular disease? I think this is a very compelling question, and I will say the only thing I can really say is that we are at an exciting time and space in narcolepsy where we'll be able to address these questions.
Mm-hmm.
You have the next question, Chris?
Yeah, let me see if there's any. There's a lot of them. Thank you for your excellent study and presentation. I think despite the longitudinal design and the effort in accounting for confounders, the results are so associational, and I wonder whether there is a plan to understand the underlying causal mechanisms. There's definitely things that need to be accounted for. It's challenging with claims data to specifically look at those factors, but I don't know, Rakesh, do you have any ideas about ways to do that in other settings?
I mean, obviously, if these are associations, and I think I always predicate if we can treat these disorders effectively, can we delay the onset of some of these comorbidities, and that can give more strength to causality. But I think, yeah, it is difficult using like claims data sets to really establish causality. We're really just presenting association. But I think using our methodology, I think the association is very, very strong. Again, using a very large data set, the association remained very, very strong. So, I mean, we hate to use the word causality, but we feel more compelled that we're pretty close.
Let's see here. Do you guys have any that you want
Yeah,
to
have you
answer?
looked at the incidence of autonomic dysfunction as a risk factor for CVD? The Devalier's paper showed a high incidence of autonomic dysfunction in T1 patients. Using the SCOPA-OT questionnaire, they were able to subcategorize these individuals with autonomic dysfunction. Do I take that, Chris?
Sure.
In terms of the autonomic dysfunction, how we could characterize that in our study?
I think let me see here. Which question was that again?
It's from 1051 from Todd Swig.
Okay. So I think I don't know, is there currently any ways to identify that within claims data specifically? I don't know, Jesus, could you maybe speak to that one?
Yeah, I mean, if we can identify this dysfunction using some of the codes, then we can try to do that. But if it's not, I mean, it's just one of the limitations using the claims data. But thank you so much for providing these references. We can definitely look into this questionnaire and see if something we can adopt for claims database analysis.
Okay, then given the thoughts patients with sleepy phenotype may have higher risk, any thought on studying patients with idiopathic hypersomnia? And so, yes, we do have this question. In fact, we just discussed this yesterday as a group. This would be a very important group to look at, just as a comparison to narcolepsy. And it's not been done. And clearly, I think using our data sets, we're poised to be able to address this question. How much are you thinking about CVD in relation to use of daytime alerting medications? So this is, Jesus, maybe you want to answer this one regarding the medication adjustments?
Yes, sure. So for the studies we presented today, we focus on the narcolepsy itself and then increased risk of cardiovascular disease. But for future study, we are actually seriously considering the effects of this medication used for treatment for narcolepsy and to see if there is any better way to reduce the cardiovascular disease for this population who need to use the medication.
All right, I think we have time for just one more question. So are there chances of increase in sympathetic nervous system during sleep in narcolepsy patients? We think, yes, I mean, related to the sleep fragmentation and the frequent bursts of wakefulness during sleep, that in itself is a central driver to elevated sympathetic nervous system activity. It has been well characterized that patients with narcolepsy have reduced blood pressure dipping with sleep. And so, there is definitely this thought that this is one of the driving forces to perhaps why we find cardiovascular disease. Okay, I think we're at the hour.
Thank you all.
So we want to thank everybody for their participation. And again, just to remind everybody that this presentation will be recorded, has been recorded and will be available on the SRS Foundation website. We hope everyone enjoys the rest of their day.
Thank you.